What is up, guys? I'm back with another video, and today we're going to be covering malignant bone tumors. So I previously made a video covering benign bone tumors a day or two ago, and now we're going to look at the remaining high-yield bone tumors that we need to talk about that can frequently show up on a lot of board exams and whatnot. So let's move right into this. This is the same exact chart that I used in the previous video on benign bone tumors. And we covered the first four, which were the benign, that I've separated with the blue line here. And now in this video, we're going to cover these three, because the last one isn't technically considered necessarily a bone tumor, except for the fact that it can move and dwell inside of bone in cases of multiple myeloma or plasmacytoma. So we'll just be looking at these three: Osteosarcomas, Ewing Sarcomas, and then Chondrosarcomas. Okay, so let's move right into this. Osteosarcoma is also called osteogenic sarcoma. It can go as either name for its title. This is just an uncontrolled pleomorphic osteoblast proliferation. So what does that mean? Well, pleomorphic just means that the cells that are going to be proliferating in this particular tumor is going to be of varying sizes. So varying sizes. All right, and it's involving the osteoblast specifically, of varying sizes. Now, what is thought to cause this? It's going to be the retinoblastoma protein or the TP53 protein mutation. So those are the kind of the proposed etiologies, although there's a lot of debate on that. Where's the primary location of this one? So this one takes place at the metaphysis, usually around the knee. So what do I mean by that? In most cases, it's gonna usually be at the metaphysis, and then in most cases it's gonna be, so here's your knee, right, the patella, and then here's the lower leg, and then here's the upper leg. So it's gonna usually be somewhere in this area. So we're referring to the distal femur. Is a common location, the distal femur at the metaphysis there, or it's going to be the proximal tibia. You can also see it in the fibula as well, but usually it's in the tibia, so the larger bones of around the knee. But don't forget, it's going to be mainly at the metaphysis. And what is this going to look like as far as when you see this on X-ray? How will this present? So this is going to present with what's called a sunburst appearance on X-ray. That's the first kind of main thing that can present as a possibility in this particular disease. And then it also has something called a Codman's triangle. So sunburst appearance on X-ray and Codman's triangle. I'm going to show you a picture of both of these in the next slide. So here's the pictures that we're going to talk about in reference to the sunburst appearance and the Codman's triangle. So over here on the left, this is the sunburst appearance. Now, I'm going to try to zoom in if I can and show you an up-close picture. So in this particular example, you're seeing that it's the fibula in this case that's affected, and you can see the sunburst appearance. So what does it mean by sunburst? It means that it literally looks like sun rays. Right here, it literally looks like a sun with the sun rays shining from the sun. If you ever look directly at the sun, it can look similar to what's going on right here. That's called the sunburst appearance, and that is very common in osteosarcoma. And then here's another case of it as well right here, the sunburst appearance. And so just another way you could see it at a different angle here. I think this is from the lateral view over here, and this is the AP view. Okay, and then we have what's called the Codman's triangle. So the Codman's triangle. Now, I've seen a lot of pictures and imaging of this particular triangle, and I want to emphasize something that's not often talked about with this. So naturally, obviously, if you look at the title, it is in the shape of a triangle, right? But then, let me clear everything. I want to show you something else that you'll notice in a lot of this, because I don't want you to get this mixed up with a disease, osteochondroma, which is covered in the previous video I made on benign bone tumors. Because an osteochondroma has these things called exostoses or an exostosis, and they can present similarly like this outgrowing of bone that you'll see around the metaphysis area, kind of towards the growth plate. But in that particular example, usually the outgrowth of bone, if it doesn't have cartilage over it, it's called an exostosis. But if there's cartilage overlying this outgrowth of bone, it will be called then what's called an osteochondroma. So a lot of times when you look at imaging, it's difficult to decipher. Are we talking about an exostosis growth that's common in osteochondromas, or are we talking about the Codman's triangle that's common in the osteosarcomas? So here's what I use to look at it. It's kind of hard to see because of the picture with the dots kind of in the way, but oftentimes you'll see with this periosteal reaction growing out from the bone, so say this is the same bone that's down below that I'm just drawing here, and at the metaphysis, so remember this is the epiphysis of the bone, this is the metaphysis, and then you have the diaphysis, kind of the shaft, the bone shaft is the diaphysis. So in Codman's triangle, you have it shaped like a triangle. That's the first thing. But you could probably also have an exostosis that could just happen to be shaped similar to a triangle just by how it's growing out. But in this particular example, you'll notice that when you look at a Codman's triangle, it goes up like this and it overshoots the triangle slightly. So you'll see this kind of thing. You'll see a kind of dark, bold, white line that'll overshoot slightly the borders of the triangle, and then it'll fade a little bit as it goes back. So notice that this did not return from the original part over here. It went in a little bit and cratered, and it faded slightly. And it's kind of hard to see because, like I said, the lines on the picture itself over here, but on the picture, this particular line is fairly boldened, and then it fades a little bit, and this original starting line overshot the target a little bit. So that's very diagnostic for Codman's triangle. That should help you lean towards the osteosarcoma instead of the other one that we discussed, the chondroma one, the benign chondroma. Okay, so that is two signs that you can see in osteosarcoma. Now I'm sorry, because normally, if you remember, in almost every disease or video I try to make, I try to give some sort of hint or mnemonic to help you remember stuff. I could not think of anything for this one, but and I wish I could, because this is one of the most occurring bone tumors. Malignant bone tumors that you have. It's the highest percentage of bone tumors are osteosarcomas. So it's really important to just kind of go over these high yield concepts here and just remember it any sort of way that you can remember it, because I couldn't particularly think of a mnemonic or a clever way to remember a lot of these details, but just drill this into your head, because this is, if they're going to ask about bone tumors, especially malignant bone tumors, this is probably going to be one of the possibilities they could ask about. This is the most common of the malignant primary bone tumors. Okay, so that is osteosarcoma. So this is very important to remember. And if you have a tip of how to remember some of these things or a clever mnemonic, please, by all means, put it in the comment section and try to get, and I'll try to answer it, and then I can give you credit and I can put it onto the pinned comment then at the top of the comments, and then give you credit for that. Okay, the next one is an Ewing sarcoma. This one I do have a clever mnemonic for. So Ewing sarcoma is caused by, it's basically a neuroectodermal. It is what's being proliferated. The neuroectodermal cells are being proliferated uncontrollably. And if you remember when we learn about neuroectodermal tumors, there's a lot of things kind of encompass in that, various diseases. They usually have that small round blue cell subtype, so that's what this is classified under. And then on histology, you have what's called rosettes. And I didn't go too much into histology because it's a little too much detailed. But basically, when you look at the histology, you're going to see these little regions that look like roses, that look like flowers kind of all over. So it's called the rosette pattern. And of course there's more detail on that, but you don't have to know too much more than that as far as for our purposes. And then you also need to know that what specifically is causing this is a translocation 1122, which is a pretty common translocation. And it's a translocation of the EWSR1 translocation. Well, let's just look at that. If you're trying to remember that, EW is referring to Ewing's, and then SR is referring to sarcoma, and then number 1. So that's pretty straightforward. So you're having a translocation of 1122 of the EWSR1 gene. Okay? Now here's where the mnemonic comes into play. Who is this most common to present in? It's most common to present in kids. think of when you were growing up and you were playing tag, maybe at recess or in school or whatever. You know, kids always say ew when they're thinking of nasty food, or like girl, if they say a little boy's around girls and they always say girls have cooties, or vice versa, girls say boys have cuties, and they say things like ew. You don't usually see an adult walking around saying that. So ew is gonna obviously, it's gonna correlate with this, Ewing Sarcoma. And then so everything plays a role according to that in our mnemonic. So that helps us remember that kids usually say this. So then you have, okay, now we have an age group about 5 to 15 years old. So kids get this. So if you see an adult, you need to be thinking something else instead of Ewing sarcoma in most cases. And then the E in the EW, right? The E helps you remember elongated part of bone. So what is the elongated part of a long bone? The elongated part of a long bone is the diaphysis, right? That's the long part of it. So that could help you remember what's the most common location that this sarcoma will present in, and that's going to be the diaphysis. And the last thing is, how does this present on x-ray? What's like a common finding that you can see on a lot of x-rays of people who have this particular type of bone tumor? And then you use this again, the ew, so because onions have a potent smell that some people consider nasty, right? Some people think they smell well, but most of the time when you think of onions, like a big stack of onions, you think people have bad breath and whatnot. So I think that you would be considered to say, oh, that's nasty or that's ill. So onion skin appearance on x-ray. This is a common x-ray finding for this particular bone tumor, this sarcoma. So let's look at what it looks like. Here's a picture showing the particular finding, and it has an arrow pointed, and I wanted to point something out. Oftentimes when you see this onion skin appearance, first of all, what does that mean? It means that at the periosteum, or at the kind of out towards the cortex of the bone, at the border, of course you see that's thickened because of being the cortex and the periosteal lining of the bone, but you'll notice that it does a little bit of an outpouching. So say this is a long bone, it'll do something like this. Oftentimes when you have that periosteal reaction, you have bone building upon bone, it will kind of it goes outwards, it pouches out a little bit because of the new bone formation for where it's forming at the diaphysis. And then where it gets the onion skin appearance is that when you would look closely at this, you'll see that it looks lamellated, like this. It has multiple layers, just like an onion does. Like if you cut open an onion, it will look like that. Now this is sometimes hard to see on an x-ray. It's hard to get a good look of this. So if it will help you then to notice that, you see here where it's happening, the bone has gotten a little bigger and then it goes back to the regular size of the diaphysis. So that will also help you. So when you see that outpouching, and when you see those kind of concentric lines, the concentric lines out towards the periosteum where the periosteal reaction's happening, begin to think that you're having this onion skin appearance, okay? And you can use that. You can use this x-ray finding along with the location of where it's at plus the age group to begin to think, oh, okay, this could be an Ewing sarcoma, okay? Now, you may be thinking, if you watched my previous video on benign bone tumors, let me just, instead of writing these all, instead of writing this, let me just go back to the opening slide where we showed the 4 main primary benign bone tumors. Osteochondroma, giant cell tumor, osteoblastoma, osteomas. Each one of these have various locations as well, and you may be saying, well, just knowing it's at the diaphysis, I still wouldn't be able to kind of figure out how you would know it's Ewing sarcoma, say they didn't give an x-ray, versus one of the other 4 whose location is at the diaphysis, right? Or something like that. The way to do that is by also understanding that there are certain symptoms that are in the malignant bone tumors that usually don't show up in the benign bone tumors. If you have more of a malignant bone tumor going on, of course it's more dangerous, but also know that usually you could have night sweats from this. You can have weight loss, low-grade fever, these kind of things. And then you could have been having bone pain for a long time. So like more of a chronic bone pain instead of you'd have maybe more of an acute bone pain in situations of the benign bone tumors. Although you can also have chronic bone pain in some of the benign ones as well. But these symptoms of night sweats, weight loss, low-grade fever, basically the typical symptoms of cancer, right? When cancer starts to get bad for a patient, they can have these kind of symptoms: night sweats, weight loss, low-grade fever, anemias, various things like that. that's when those kind of symptoms should kind of start pointing you towards a malignant bone tumor type. So that can also help you to figure out, okay, which of the types of bone tumors am I trying to basically draw from and begin to pick from. Okay, so back to what we were talking about. This particular sarcoma, the Ewing sarcoma, the two main signs, you're looking for the outpouching and the concentric lines for that what's called the onion skin appearance. Okay, and remember the rest of the mnemonic that little kids typically yell EW, ew, when they're thinking of nasty things. And then E also stands for the elongated, E for elongated part of bone. That's where the most common location it's going to be on for the bones. So that's going to be the diaphysis. And so you can see how that mnemonic works. You could even use the mnemonic for, remembering the E for EWSR1, but that part's pretty easy to remember because it literally just stands for EW for Ewing and then SR for sarcoma, and then just add the number 1, right? So that's not too hard to remember. The hardest part to remember in all this is really the details of what particularly causes this particular bone cancer, and then knowing some of the histological things that you're going to have to remember on your own. Okay, so those are the important features of the Ewing sarcoma, and then the Chondrosarcoma is the last main one we're going to talk about. There's something really, really unique about this particular disease in almost all of the other ones. In almost all of the, and that's including kind of like both groups. In almost all of these other ones, not all of them, there may be 1 or 2 exceptions, but usually you see these in young people, these primary bone tumors. The kind, basically, and the reason I keep saying primary is because in primary bone tumors, it basically, the cancer started at that location, didn't metastasize from, say, the lungs or some other organ or anything like that. It began at that location, so it started from there. And so in primary bone tumors, you often will see that the particular, as far as who gets it, it's going to usually be in children in most cases. But in the case of a chondrosarcoma, this is very unique because it's mainly elderly patients. It's older patients. You could say, 50 plus, 60 plus. It varies depending on the resource you look at. But just think of older patients. So you don't usually see this in a patient who's 10 years old, whereas a lot of the other ones you absolutely would. Okay, so this particular one, chondrosarcoma, is a malignant tumor of connective tissue that sometimes resides in the medullary cavities of bones. That's very high yield. Things you need to know about this. It usually occurs in the elderly, and when it does happen, you will see on x-ray it will be damage to the inside part of the bone, the medullary cavity. This is distinguished from osteochondroma. Again, if you didn't watch the previous video on benign bone tumors, I give more of a foundation to some of the things that I'm talking about. But this is a benign bone tumor, osteochondroma. Do you see how you could easily mix that up with chondrosarcoma? So don't mix these two up. So what are the differences between the two? Well, first of all, the chondrosarcoma, the malignant one we're talking about right now, happens usually in the medullary cavity of bones, and it also happens in elderly patients. Whereas in osteochondroma, which is a benign bone tumor that I talked about in the other video, that one usually doesn't take place, and it usually takes place in younger populations, like kids and stuff like that, and teenagers. So this is younger patients. And then this particular, in the osteochondroma, it targets specifically at the metaphysis, basically at the physis, or what's called the growth plate. So those are kind of two, if you can distinguish those kind of things, you can begin to figure out, oh, okay, so I can kind of start to piece together some of the differences. And then another difference between these two, that this disease is very common in pelvic bones, shoulders, and I'll just go ahead and add this in as well. It's also common in a lot of other areas of the axial skeleton, okay? But these are kind of the two main ones that you'll find these. So that's another really important difference to note. And I'm going to show you a picture now of a chondrosarcoma, and you can see right away. This is fairly contained inside the medullary cavity of the bone. Basically the part of the bone that where it begins to get more radiolucent or less substance to the bone. There's an opening there in the medullary cavity where the bone marrow is kept, and that's where this particular bone tumor, malignant bone tumor, usually will present with. Now, as if this progresses and gets more dangerous, this cancer can begin to penetrate farther and farther outside towards the cortex until it eventually exits out as it gets worse and worse. But the initial presentation is usually going to be, it starts and is confined to the medullary cavity. Okay, so I hope this video helped you. This is a lot faster than the other one and a little bit quicker because there was this one only had 3 diseases we talked about and the other one had 4, and I kind of laid more of a foundation in the other video for those kind of opening up for bone tumors in general. So if you want to learn more and kind of learn a lot more mnemonics and tricks, I had way more mnemonics and tricks to remember this stuff in the video for benign bone tumors versus this video on the malignant bone tumors. But I want to emphasize to you that this list I gave you, if you're asking me which is the most high yield, I'm still going to say which, if you're asking which would you probably see a question on, it's going to be these two, Osteosarcomas and Ewing Sarcomas. So these two are very important to know, and sadly I don't have a way to remember a lot of the details of the Osteosarcoma, which is the most common primary bone tumor as far as percentage in patients. Okay, so I hope this video helped. If it did, please like, subscribe, comment any sort of tricks that maybe you know that you use to help remember a lot of the details of osteosarcomas. And if I see it and I really like it, I will pin it to the top of the comment section. I will see you in another video. Bye, guys.